I thank Giridhar for including me in this symposium. As Gopal said, there will be an overlap, but my talk will be more on surgical technique, and I'll touch upon two controversies that we can discuss upon after my talk. My technique has changed. We started off with 20 gauge, all of us started off with 20 gauge, and now switched over to MIVS 23 or 25 gauge, especially for a macular hole or an ERM. We prefer a 25 gauge MIVS. And now we are doing more and more of phaco-vitrectomy. With the advent of phaco and MIVS, I think our combined surgery rate has gone up, because we know that the phakic patients will sooner or later develop cataract. But having said that, I would tend to do cataract surgery and combined vitrectomy only in those patients of significant nuclear sclerosis. The lens is absolutely clear. I would go ahead with just ERM surgery. And we started off with no staining. I used to use a pick or a bent MVR blade to create an edge and peel the epiretinal membrane. Then we switched over to triamcinolone when it came, and now we are using Brilliant Blue. And we started off with just doing ERM peel. Then we said we did ERM peel, and then we did the ILM peel. And now my technique is to do both ILM and ERM peel together in an ERM case. And as Dr. Gopal has also emphasized, I don't use gas as a tamponade when I'm doing a pure ERM surgery. I don't feel the need for it. And if we could probably do some fluid air exchange at the end of surgery just for obtaining some watertight closure of the wounds. Otherwise, we do only, we don't need tamponade. This is how we do the surgery without staining. We're not using any stain. The ERM is very well visible. I use the forceps to pinch and hold the ERM, and ERM is peeled, and we're able to remove the entire extent of the ERM without much problem because it's loosely attached. And in this particular patient, we didn't do any ILM peel, and no staining has been used. Now, what I am doing here is I am staining the ERM first with the Brilliant Blue, and I have done the ERM peel first. This is what we did when we started using the Brilliant Blue. This is how we did the ERM peel. We did the ERM peel, though the Brilliant Blue stains ERM less than ILM, but it does stain it quite well enough for us to see. As you can see here, the ERM is seen well, and it is stained with Brilliant Blue. And after finishing the ERM peel, we would re-inject the Brilliant Blue and then do the ILM peel. So here, after finishing the ERM peel, the ILM is being peeled in this patient. Now I realize that it's not necessary to do this double maneuver. If you look at this diagram, I realized that when you use Brilliant Blue, there is a negative stain and a positive stain. Those areas in which the stain is very poor actually have epiretinal membrane that is negatively stained. And outside the area, wherever there is a good staining, that is the inner limiting membrane. So what technique I am using now is a single peel, wherein I start my peel outside where the ILM is seen, outside the area of negative staining, go to the positive staining, start the ILM peel, and I peel the ILM, and therefore the ERM also comes along with the ILM in one go. And this is the technique that I use now. So we don't need to stain two times, we don't need to remove them separately. And when I'm using Brilliant Blue, I don't feel the need to do the stain under air. We inject Brilliant Blue with the fluid and just leave it for about 10 seconds and then remove it with a soft tipped cannula, and that seems to stain the structures quite well. And this is the combined ERM ILM peel that we practice today. So at the end of surgery, you all know that we have to check the periphery of the retina for breaks, and you close, and that's nothing special about it. So I think this topic has already been touched and discussed a little bit. Just to reiterate what I do operate when the vision is less than 6/12, attributable to the structural changes seen on the OCT, correlating with the clinical findings is always equally important. What if the vision is 6 by 12 or better? I think this has already been discussed. We can have more discussion in the end. But a very symptomatic patient in whom there is a documented drop in vision with increase in the OCT changes, definitely you could offer surgery after discussing with the patient. But this is one gray area. Of course, we all know the various changes that OCT shows in macular hole. Now, we know that in macular hole, vision rarely improves to 6 by 6 in patients who have less than 6 by 12 vision. With lower vision, more improvement is seen, less improvement in chronic cases. ERM peel does not seem to alter the outcome, though we continue to do it, but it has been proved to reduce the recurrence rate. And this has already been alluded to. The outer retinal structural changes are more important as far as visual results are concerned. What are the dilemmas in ERM surgery? Should we operate on patients with good vision? We'll have discussion on that. Whether to peel ILM or not. Can we predict visual results with better OCT machines? And lastly, do we need to do vitrectomy at all? I would like to present two publications and then conclude. This is recently published in Retina from Italy, where they have prospectively divided the patients into two groups. One group, they did not do any vitrectomy. They just introduced 25 gauge cannulas and used the light pipe and a 27 gauge ERM forceps to peel the ERM without staining and come out. In the second group, they did a standard 25 gauge vitrectomy with ERM peel and compared the two groups. They had 40 patients in the vitrectomy group and 39 in the non-vitrectomized group. Vision improved in both the groups but was better in the non-vitrectomized group. And as could be expected, nuclear sclerosis much less in the non-vitrectomized group compared to the vitrectomy group. So do we need to do vitrectomy at all when we are doing ERM peel? That's one question I would like us to debate. The second is this study, again from Korea, where they have studied the photoreceptor changes, especially the cost line and the visual outcome after ERM surgery with or without ILM peel. They had two groups, 40 eyes with ILM peel and 69 eyes without ILM peel. What they found was that with no ILM peel, the visual and the anatomical results were superior, were better at 1 month. But at 6 months and 12 months, this difference disappeared. And of course, with other studies, they also showed that the recurrence rate without ILM peel was higher than with ILM peel. This brings us to the question, is ILM peel needed at all? Are we achieving anything better, or are we really damaging the retina more by doing ILM peel? So these are the two questions at the present time that we probably need to debate on. So in conclusion, I think we can debate some of these points. ERM surgery is not challenging as far as doing it is concerned. You know that once you have in your list an ERM peel, you are relaxed. You know that it's not such a challenging surgery. However, it is still challenging to decide when to operate, because we all want our patients to do well. And those patients in whom the vision does not improve or patient is not happy, he can make your life miserable. That is one thing we all want to avoid. And at the present time, I think we all peel ILM even in ERM surgery. I don't know, we can take a vote on this. I am continuing to peel ILM, but maybe we need to relook at this, whether we should peel or not. I use Brilliant Blue. I have not used triamcinolone for ERM surgery in the last 2 years once I started using Brilliant Blue, and I think it works quite well in my hands. As the OCTs improve, we have swept source and ultra high definition OCTs and other OCTs come, probably we'll have more and more inputs to tell us about the structural changes. Even before surgery, we could probably pick out those patients who would benefit from surgery or who would not benefit from surgery. And lastly, maybe next year when we meet, we might have more papers on ERM peel without vitrectomy using a 27 gauge approach that's available. As the small gauge instrumentation is becoming more and more refined, we may be able to go into the eye without doing vitrectomy, inflict minimal damage and do what is only necessary. And that's truly minimally invasive surgery. So with this, I conclude. Thank you.
Thank you, Murli.